There's a limited role for treatment of feet if they're symptomatic. Sometimes you can do a calcaneal osteotomy, which is to operate on the back of the foot and shift it over and lengthening the calcaneal neck by opening and inserting a wedge of bone to force the foot back over into place. The calcaneal osteotomy redistributes the collapsing stress of the foot by taking the heel and shifting it over so the back of the foot no longer looks like that but comes more straight down afterwards so that it's not collapsing. And at least for that aspect of the foot deformity, it can be successful. But we try to do it as late as possible during life so that growth doesn't cause a recurrence of the deformity later on. Other skeletal findings can involve other parts of the body. The sternum, for instance, is well known to cause deformity in Marfan syndrome, but also in Loeys-Dietz syndrome it can either protrude outward or inward. And the role for surgery is somewhat gray. It's an elective procedure in many cases, and that can be determined by consultation with your pulmonary specialist, with your general surgeon, and by your own personal preferences as far as the deformity aspect of it. One of the most striking findings in Loeys-Dietz syndrome involves the neck or the cervical spine. There's often deformity and instability resulting from both the loose ligaments and also the developmental effects of this syndrome. At least half of patients have some formation defect or instability, although it's not always a clinical or symptomatic problem. And just to clarify some of the terms, some of the bones have special names. As you know, the cranium is the base of the skull and its surrounding. The atlas is the first cervical vertebra. The axis is the second cervical vertebra. And the axis also has a process called the odontoid process, which is this peg-like piece that attaches to the ring of the atlas by a ligament. And then below that you have 5 other cervical vertebrae. The majority of the problems in Loeys-Dietz syndrome involve the upper cervical spine, as they do in most children. You can have formation defects, and at least 15% of patients in our series had an incomplete ring of C1. So this bone should go around and join from one side to the other, but in fact there's a gap there. It can also exist in the back. This is the back of the atlas, and it should join together, but in fact there's a developmental cleft here, which isn't particularly a problem unless you're operating and you want to make sure that you know what the anatomy is. You can also have a side-to-side mismatch of the atlas on the axis, and that doesn't seem to cause too many clinical problems. It just is a result of the ligamentous laxity and probably a developmental variant, again, due to this syndrome. And I think the role of this receptor in closure of midline structures of cervicocranial junction is quite related to the hypertelorism and other things that you see. You can also have subluxation or instability of some of the upper cervical vertebrae. We've seen cases of C1, C2, C2, C3, and C3, C4 subluxation, which can occasionally cause pressure on the spinal cord and may need to be fixed surgically. The lower part of the spine, or the thoracolumbar spine, comprises most of your vertebrae, and as you grow during life, the spine really requires an intact muscular and ligamentous structural support to stay straight. So with the pressure of growth, many children with imperfections in muscle and ligament support will develop a severe scoliosis or collapsing of the spine. And we found some degree of scoliosis in over half of our Loeys-Dietz patients, although most of them had a mild to moderate degree. The average angle of the curvature was 29 degrees. What I've shown here is an extreme example of a 100-degree curve. 3 patients in our series had to undergo some form of spinal fusion, and 2 more were too young for that and were treated with growing rods, as you can see here. Braces can be used for mild cases of spinal curvature. They typically don't stop worsening of the curve, but they may slow it a little bit, and they may improve sitting in kids who have a hard time controlling their trunk because of extreme ligamentous laxity. In general, curves somewhere between 30 and 60 degrees probably have some benefit from bracing, but when it gets too big, the brace is just too uncomfortable to be practical and probably not worth using. For some of the more extreme cases, growing rods can be used, and this is a patient who had an infantile curve that was treated with this set of rods, and you can see how it elongated and expanded the spine and allowed it to grow straighter and straighter. And as seen from the side, the spine was kind of collapsing, and the rods actually supported it, and the patient actually gained about 5 or 6 inches between there and there with the use of these growing rods. And so typically these rods are expanded approximately once a year with a relatively straightforward, simple procedure to make them stretch out and kind of drive the spine into a straighter position. So when bracing fails and the deformity reaches a severe degree of, say, 70 degrees or so, that's when we typically will consider this option in a child who has growth remaining, usually under about age 9. Throughout the vertebrae, there are many other findings. You can have slippage of the vertebrae or spondylolisthesis. You can have early degeneration, we saw rarely in one patient. And you can also have some degree of dural ectasia, although it doesn't seem to be quite as severe as you see in Marfan syndrome. Spondylolisthesis is a slippage of the vertebrae. This is an example of one patient in which the vertebra of L5 was slipping forward on the sacrum more than 50%. And typically, if it's more than 30%, we will fix that and stabilize it so that it doesn't continue to get worse. So what we've learned through studying patients with Loeys-Dietz syndrome and being involved in their care is that recognition of the facial findings and the extremity findings can be very beneficial and proper referral for management of the aortic and vascular problems. Ligamentous laxity is much more of a problem, and we don't have a solution for that. It's not always amenable to surgery because new ligaments will often stretch out as well. Talipes equinovarus or clubfoot can be treated and made improved so that you can stand on the foot and wear some degree of normal shoes. Hand contractures typically improve with time, stretching, and occupational therapy. And cervical spine anomalies need to be recognized and straightened out and stabilized in some cases. So I tried to give you a little bit of a run through here, and I just wanted to leave the rest of the time open for questions and comments on your own experience with some of these features. Yes?
My younger son was born with club feet bilaterally. He's 8 now. He's had a surgery on each foot. He's had Botox injections in each leg. He's had the casting. He's had the bilateral ankle and foot orthotics. He's had the thigh cuffs. We are at the point now where the last visit they gave me a script for orthotics, not the ankle and foot, but just the insert in the shoe orthotics. I heard you say that for flat feet, it doesn't really do much for the foot. For club feet, we're on our second orthopedist. The first move, it wasn't we didn't like him, he just left town. The second one is about to leave town. So I'm going to have to make another change in this doctor for my son. But what he said to do for this year is try the orthotics, come back in a year to see the partner who's still going to be here, and then maybe look at another surgery. But I also heard you say that surgery is not your recommendation anymore. So where does that leave us?
Well, I think that probably a blanket answer wouldn't be probably helpful, but in general, orthotics are only used, I think, if there is a feeling of weakness or focal pressure on the foot. If there is a callus forming, too much pressure on one part of the foot, then oftentimes you can redistribute that pressure by using the orthotic. But for support and weakness in the ankle, you have to balance the possible rigidity and the bulk of the brace versus the possible benefit which may be entertained. If there is severe pain in the foot, which may be due to degeneration, there may occasionally be a role for surgery and fusion. But the one thing we've learned from Loeys-Dietz syndrome is the ligamentous laxity causes unpredictable results and some degree of overcorrection. So ligament surgery and realignment without osteotomy or bone surgery is a little bit unpredictable and probably not to be done except as a last resort. So we try to work on the bones as much as possible and the ligaments as little as possible. But I think probably someone would have to examine the foot and come up with a recommendation. But in general, unless it's a really symptomatic, painful foot, I probably would be leery of further surgery. No, I think that we don't know enough to say that one activity is bad and that you should avoid it in general. I think the passage of time and the aging process is kind of hard on all of us, but for a young person without a specific diagnosis of instability of the wrist, I don't really foresee any unusual problems for you. I think clearly the ligaments are looser than usual, and there is more of a tendency of fatigue and pain, but I think you should just let your experience be your guide. I can't really say that there's a high likelihood of tendinitis or overuse syndromes. I think there's some of these answers are just not ideal. Sometimes it's just a matter of watching and waiting. Bracing probably can help some of the milder curves, as I said, but they can't help the severe curves. We really are aiming to do a couple things with surgical treatments. We're trying to prevent severe effects on the heart and lungs. If the curve gets more than 70 or 80 degrees, then that can have medical effects on the heart and lungs. We're trying to prevent that. And that's why we will sometimes do growing rods to help allow the thorax to get tall and the ribs to prevent further twisting. So growing rods are certainly done at that time. But a minority of children require that. Most of them, I think, are just treated by observation, and a few of them by bracing. And in some cases, a mild to moderate curve is just left alone and is tolerated. Scoliosis in a mild form is not harmful medically. It doesn't affect the heart or the lungs. It's only when it becomes severe that it becomes so. So the art is trying to predict who is going to be at risk for severe worsening and medical effects, so should be put through that. But typically, we don't try to overburden kids with treatment for the milder curves. Yes, so the question is, how should you monitor and manage kids with bone density? And we've seen a couple kids, including one that Hal and I follow, who had kind of a fracture of her femoral neck, unrecognized. And by the time we recognized it, it had actually healed itself. And she'd been limping for 3 weeks, and we finally found out why, but by that time the bone had healed. So that was kind of striking. We don't know the overall incidence of osteopenia and osteoporosis, but clearly it exists. I think the best way to monitor it is simply by looking at the x-rays and deciding whether a DEXA scan is needed. Probably it's a topic for further research, in which we, in the sense that we should probably look at the overall prevalence and maybe instituting some scanning, DEXA scanning for the patients. The only real treatments we have for osteoporosis are appropriate amounts of activities within the range of somebody's abilities, making sure their diet contains kind of an average amount of calcium and vitamin D, and occasionally in some patients we've done bisphosphonate treatments, which is to give a medicine that inhibits bone resorption so that the buildup can take place. And that has a modest effect in children in general. We don't know specifically how well it works in Loeys-Dietz syndrome, so I can't say that there's a specific well-defined role for that. But I think it's mainly a topic for further study, and we need to probably look at the overall prevalence and the appropriateness of bisphosphonate treatment or other bone resorption and anti-resorption agents. So, I would say stay tuned for that, and it's a topic for further research. So what other activities would you recommend for weight bearing, for bone buildup, muscle strengthening, and so forth? It's really an individual matter. It depends on what the strengths of the person are. If the foot is not an issue, then walking is maybe an option. Treadmill, bicycling is another option. Swimming probably is not so ideal for weight bearing because the weight is actually relieved by the water, but it's good for overall cardiovascular fitness and muscle strengthening. But I think you should kind of look at the child's individual problem areas and strengths and their interests and what's available to you, and a physical therapist can be an option to help you advise what's best for that child. The person that can help you with bone density may be your endocrinologist or your nephrologist or occasionally your orthopedic surgeon. So different centers have different ways to deal with osteoporosis management and treatment. at Hopkins and Kennedy Krieger, we have several people that are interested in that. And in each medical center, there typically is a team that can deal with both children and adults for their bone density issues.